Good afternoon, everybody. It's a real privilege to be here, so thanks for the invitation. My name's Amar. I work not too far down the road from here at the John Howard Centre. I don't know if you've passed that building, the old Hackney Hospital, which is now a medium secure unit. Part of my job is consultant forensic psychiatrist. The other part of it, most of my job now, is leading on quality across East London Foundation Trust. And so what Victoria asked me to do this afternoon is just to tell you a little bit about our experience of trying to build an infrastructure and a movement for improvement across our organisation and what it takes, what it's taken us, some of our learning, and then you can think about how some of this resonates with you and your roles at the Homerton, and then we can take some questions and discussion about it at the end of the afternoon, if that's okay. So. What I was going to try to help you think about is the key elements of what it takes to build a system at scale, and then how you engage people in it, really. In case you don't know who we are, obviously there are bits of our organisation that are right on your doorstep, but then there are bits that are quite far away. So I thought I would just let you know who we are and where we work, first of all. So we started off really in this patch of East London, providing mental health care for the 4 boroughs from City of London out through East all the way to Newham. And as many trusts have, we've diversified over time, so we now cover forensic services across a bigger patch of North and East London. We've got some satellite services dotted about London, and for about nearly 2 years now we've been providing all mental health services in Luton and Bedfordshire. So in total a population of about 1.5 million people, over 5,000 staff across about 150 different sites. So quite dispersed. And I guess that's one of the first things to mention is that when you think about improvement, it has to be couched in the local context, so the things that feel real to people working in that area. So for us, these are the things that we see as real challenges, but also opportunities for us in the population we serve. There's something about the diversity of the people in our patch, as you have in Hackney. There's something about the social deprivation, about the dispersion we have, which makes improvement quite difficult, but helps us think differently about how we might build a learning system across such a large geographical span. I think one of the things that we're quite strong in our belief on is the purple circle there, that you probably can't ask your staff to innovate and generate new ideas and test them out without fear of failure, unless you're pretty secure and you have some sense of safety psychologically. So having some robust finances and assurance systems and having stable leadership, we think is pretty key to then allowing people to let go at the top of the organisation and allow people to be freer, closer to patient care, so they can do what they think works and test it out and fail, but fail fast and learn. In the NHS, we're really familiar with this approach to quality, which is set a target or a threshold and then see if you're meeting it or not, a really binary thing, either yes or no, and then focus your attention on those that are not meeting the standard. And obviously that, you're always forever chasing your tail with that. And there is a role for this, so we have to make sure we're meeting minimum standards, but we should probably use this more sparingly than we do, just to look at minimum standards. And you know, we were no different to most trusts 4 years ago. This was our board's scorecard. I don't know whether you see things like this in reds, ambers and greens, RAG-rated, hated spreadsheet. So this was actually our board scorecard in 2010. So the board looked at this on a Thursday, much like today. Today we had a board meeting, and 2 days later, we had the worst possible safety incident you could have in a mental health unit. But looking at that, you'd be pretty assured, right? So they came away from Thursday's meeting thinking things are not too bad. And if you take a closer look at this, you will see that this is just a load of nonsense, right? Because if you look at that, if you look at the top one there, MRSA bloodstream infections is something you guys contend with, but we're a mental health provider. We haven't had one ever. And yet it's 0 because it was a monitored target, a national target, performance managed, so we reported it as green, and it's still been green. So there's a little bit of a fallacy about red, yellows and greens, arbitrary targets, and actually things that you measure that are meaningful to what you're trying to provide as an organisation. So 2 days after this, on the Saturday, a patient killed another patient on one of our wards in Tower Hamlets. Okay, and the patient who was killed was supposedly on 15-minute observations, and so that led to quite a lot of internal dialogue about really how sure can we be that we're doing the right things to support our staff to provide high quality care. A couple of weeks later, another patient killed themselves on the same ward, and then 3 months later, another patient nearly killed themselves on the same ward. So the Tower Hamlets Gazette front page was ward of death that month. This was the Guardian. And that whole summer led to a real rethink about, you know, what are we doing and what could we do differently? And many organisations have that kind of burning platform to start thinking differently about quality. And if you hear the stories from many places that are seen as now the high-performing, really quality-focused organisations, they'll have a similar story. It'll be a slightly different incident each time, but there will be something that's made the leadership really question their existing patterns of behaviour and what they currently do. So that led to us really asking the question. And asking the question, if you're in a leadership role, is half of the battle, really. And they started thinking and looking beyond our organisation to see what else is there. And that's when we came upon improvement and started thinking about how could we start using improvement in a sensible way to shift the culture in the organisation to one that's more where power is held closer to the front line and less at the top of the organisation. And it starts really with the executive team. So this is something you're going to have to think about at Homerton is how does your executive team behave and what are the things they do that generate a feeling of power or powerlessness within teams at the front line, and how much decision making is made at the top of the organisation versus how much is left to people at the front line to work out using a method to learn and data to help inform the decision making. And so our exec team have been on a bit of a journey over the last 4 years of really trying to think about what they do and where they spend their time, what they pay attention to, and how they make decisions. And things are different now to how they were 4 years ago. We then started making the case for this internally. This sort of thing doesn't happen just by magic. You have to really think and decide whether you want to go down this route. And we spent quite a bit of time talking to all of our stakeholders inside and outside the organisation about what this would mean, how would we do it, what would it take, what would it feel like, and making the case for change. This was back in 2012-13. And then we did a number of things to help encourage people and engage people in just starting a conversation about quality improvement. Most people thought that their jobs were, and most people come to work to improve things and to do the best they can. But the language of quality improvement and the actual method of it is a little bit alien. Most of us haven't really been exposed to it, so it does take time to really get people comfortable with it. And we did a number of these things in the early days, before we had any money, before we had any team, to just start exposing people to it. And these are things that people can do when they have very little resource. Obviously, when you start getting more serious about it, you'll start getting to the bottom stage, which is really developing a strategy involving everyone, building a business case for multiple years of investment in this. And then some of the places that have really been successful have had an external guide, a support for this, which is what we went out to find, and that's how we became partnered with the Institute for Healthcare Improvement. And at the end of it all, these are the sort of things that I think we hold dear and want to try and nurture through improvement. And we think are starting to change in our organisation, but we're still very early in our journey. In the way that we've designed our work around improvement, these are the principles that we have tried to make sure at the forefront. So we try and make sure any improvement work we do is really meaningful to people. We try and find ways to make that happen in the design. Some of the things that people are tackling are really difficult. So finding ways to make it feel possible and to help encourage people that this is doable is really important. In the NHS, where change is constant, even within trusts where change is constant, helping people engage with something is really dependent on making people feel like it's going to be permanent. Why would you engage with something if you think it's going to go away again in a year or two? Why invest your own energy into it? And that is a leadership function, really, to help people feel secure that this is something that's going to last for 10 years, or we're really going to have a go at it for a long period of time. So if you come to Elft, this is on our wall now in our headquarters. This is sort of an indelible statement of what we're trying to do and how we want to try and involve everyone in getting there. And familiar with these sorts of things? What is this called? Hey, well done. So this is our driver diagram. I mean, we have hundreds of these for all of our projects, but this is the one at macro level. So as a whole organization, how are we trying to, what's our theory about how we're going to try and achieve our goal? And the blue box there on the left is our goal. And when I first had a conversation with our chief exec about this, it was not an easy one, because we were really used to very annual planning, really focused around the business, the money, the contracts, and less about aspiration. And so it's quite a big change to make, to put that in black and white, and to say you want to achieve something quite as ambitious as that. So the 4 boxes in orange are the things that we spend most of our time on. And you'll notice that projects is just one of the 4. So we spend as much time engaging people, as much time building skills across the organization, and as much time aligning the organization around improvement as we do on our projects, which is interesting. Because I don't know that many people balance their time in that quite the same way. So I'll show you a little bit about what we do in each of those 4, and then show you some of the work that we've been doing. So in building the will, there's lots of different ways of engaging and involving people in this. And we do some of the usual things and some things that are a little different. If you haven't yet been to our website, it's the one-stop shop for anything QI, and we've made it intentionally public so anyone can see it, any of our patients can access it as well. And as much of our learning goes there as possible. We do quite a bit to engage the wider system in improvement, and we think we have a responsibility to do that, because I think individual organisations by themselves can only do so much, but we need the whole system to support this for it to really be sustainable, which is why we end up working a lot with commissioners, the CQC, NHSI, and others. And we celebrate. We spend a lot more time celebrating than we ever did. So this is about the balance between the dark spots in your organisation, where leadership tend to spend their time, and the new balance between really celebrating, going out and finding the bright spots and learning from those. And we use different mechanisms to incentivize and motivate people. For some people, publishing works, and we publish as much as we can. But it's not an accident that as you start transferring the balance of power within an organization, that staff feel more engaged, more satisfied, more motivated. They feel more able to contribute in the work and improving their work. And that's what we found in our staff survey results. So top tips from me around building will are these ones here. And hopefully there's something in there that you can take away to the work we're doing here at the Homerton. On building capability, most organizations that have been down this road will have something like this, a model for who needs what skill at what level of the organization. It's a very busy slide, so I apologize for that, but it is our plan on a page about how we're building capability. And obviously we update this every year, and we think about what are the needs, how can we meet those needs, and what depth of capacity do we need in each of these levels. And so we have a range of options now for people to access QI learning depending on their role and their job and what they need in that job. From 6-month options like this one, where there's a range of different modes of learning, from face-to-face to virtual to coaching, and 700 people have now gone through this in the last 2 years, to a much more classroom-based, fun-filled, activity-focused introduction to QI, which is what we've developed here, the Pocket QI, which 300 people have now gone through in just over a year. We really firmly believe that improvement is a team sport. It can only be done in teams for it to be sustainable. So this is why we really think coaching is key. So we've developed an improvement coaching course with the IHI, and we have a number of coaches now who support other teams in their improvement work, and who have real skill in improvement, but also real skill in coaching teams and the softer side of engaging people and the dynamics within teams. And we also offer support for our patients and service users to be involved in improvement work. And this isn't just about training, this is about things like building confidence, helping them think about how they'll contribute within a group. We now build it into the recovery pathway for people as they leave mental health services. So it's quite a big part of our thinking about how we can prepare people for employment after they leave hospital. So there's some big takeaways from me on building capability. The alignment piece is probably the hardest one, and this is about the the thing you have to think about at the beginning is how would you even make time for this? Most of us are maxed out already. So if you really want to do improvement, you have to find time to do it. So we tried a number of things 2 or 3 years ago to make time for this, including cutting our audit program by 70%, running a big campaign to ask teams what they did that they thought added little value that we could stop or think differently about. And I guess it's an ongoing challenge really to find time and space to do improvement work, but it's a really important one. We also think the infrastructure around teams is really key. Teams need support with this work, so this is the support structure we've built around a team. This is our intensive care unit across the road in the City and Hackney Centre for Mental Health. And around them they have this, when they work on something, they have a sponsor, someone really senior, a director level person, paying close attention to how they're getting on, helping them when they get stuck. They have a coach, they have loads of resources, and they have someone from our people participation team who helps them think about how to involve patients, service users in the work, because that's not always as easy as you might think. We've also really moved in terms of thinking about how we use data. So from that red, amber, green scorecard, this is now the way that our board looks at data. So this afternoon, this is what they looked at in our board meeting for quality. A consistent set of measures, 35 measures that the board and our patients and our staff have together co-designed, looked at over time as control charts to help them understand the variation that's existing, so they can pay attention where they need to pay attention and not pay attention where they don't need to pay attention. And it's really changed the conversation. It's all very well doing that at the board, but teams need data in the same way, so we've spent 3 years now really trying to make sure every team has their data as run charts and control charts. Do you know what run charts are, if I use the word? So it's just plotting data over time, like a line chart, but using analytic statistics to help understand and predict where your next data point is going to land. So that's the power of run charts over looking at aggregated statistics. So here's some big takeaways from me on what we've learned around alignment and integrating improvement into the day job, which is really still an ongoing area of work for us. So lastly, just finishing up with our project work, and there's this tension that exists around how much improvement should be bottom up, really led by the teams, and how much needs to be dictated from the top of the organisation. And I don't think there is a dichotomy as clear as that. It needs to be a balance between the two, I think. We really strongly believe that we need to let people work on what matters most to them. Here's the bit about meaningfulness, making this feel meaningful. We let any team work on whatever they want to. And that's quite empowering for people. It's also quite difficult if you're a leader to say, we're just going to let them do whatever they want. But ultimately, what matters to teams at the front line and to their patients really aligns with what matters to senior leadership. Funnily enough, it does. And so actually giving people space and time to really think about that and have a conversation about what is the most important thing we need to work on has led to a lot of commonality between what the board cares about and what teams care about. And with the right kind of infrastructure in place, we've seen our number of projects go up and up and up. So it really has taken off, and people are keen to use the method to improve things. The danger, obviously, is that you get 1,000 flowers blooming, and it doesn't really help the organisation move in a common direction. But we have found that what people want to work on at the front line does coalesce into things. Lots of our inpatient wards are worried about violence because people are getting hits on the wards all the time, and that's a concern for staff. It means that patients spend longer in hospital, and it becomes an unsafe place for them to be in their recovery. But it's also a big issue for the trust. It's our number one safety incident that's reported. So there is a lot of linkage between what's important at trust level and what teams care about. And so we have now some big priority areas where lots and lots of teams are working together, and we build learning systems around them to help them learn from each other. So last off, what have been the outcomes? I guess you'd probably be asking, so what? And I guess, in some of the testing units where we've been working on violence reduction, probably the biggest safety issue we have, where if you look at the evidence, there's nothing. If you do look at RCTs, there are none. If you look at systematic reviews, there are none. So simply using the evidence base doesn't really tell you a lot about what to do. This is mostly innovation. And our teams have found that they can reduce violence by about 50%. So our adult wards that have been testing have halved their levels of violence. We've done this in adults, in older adult wards, in forensic wards, and in the adolescent unit. And all of them have managed to reduce violence in a way that's really been empowering for them. Suddenly something that seemed intractable is actually not. And over the whole organisation, we've seen a drop by about a quarter in our violence levels. And you know, in terms of how that compares, we're the red dot in that against all other mental health providers in England. So it's not just a reduction we're seeing in East London, it's a reduction compared to other trusts as well, which is really exciting. And not many places in the world have ever managed to tackle violence in this way that we know of. Waiting times is another one. So if you ask our community teams, if we'd asked them 2 years ago to reduce waiting times, the very first thing they would have responded is, if you want us to see more people and see them quicker, we need more money, more staff and more money. And yet, by empowering them and letting them loose with very simple tools through QI, they've just looked at what they do in their day-to-day practice, and they've redesigned things. They've made things quicker, more efficient, they've worked together, and they have reduced waiting times in the community. And they've reduced non-attendance at appointments, and all of that whilst seeing more referrals come in the door. That's the middle graph there. So despite having greater referral volume, they're now seeing people quicker, and more people are turning up to appointments. So it's fascinating, really, that a topic we were too scared to talk about, even with our community teams 2 or 3 years ago, is something that they have shown they can improve, just given the right kind of environment and tools. So that's our story, and I hope there's a few things in there that you could take away from it to apply to the work you're doing in your team or to the whole organisation at Homerton. Thanks very much.